Natal, Ms. Nomagugu Melanie, and also your co-program director, Professor Gonda Perez, the Premier of, I also nearly said KwaZulu-Natal. You just infecting me with KwaZulu-Natal. The Premier of our host province in absentia, Premier Lusufi. The Premier has asked to be excused, just some urgent matters which he needed to address quickly. My colleague, the Deputy Minister Lomo, MECs, thank you very much. Quite a lot of MECs are here, which emphasizes the extent to which our colleagues in the provinces take very seriously this Presidential Health Summit, which we'll be having over these 2 days. Our bosses from Parliament, because they are our bosses, we report to Parliament. So we're happy to have the chair of the committee, portfolio committee, and also members of the portfolio committee on health. Our partners, starting with WHO, our country director, Dr. Kalua, other members from the UN family, other partners from various embassies who have also joined us. Of course, our other boss, the presidency, represented by Prof. Shisana from the executive side. All the partners in this journey, from the private sector, from labor movement, civil society, all other organizations which have been part of this journey from 2018 as we go through the second phase this morning. Good morning, ladies and gentlemen. Sanibonani, Dumelang, Molweni, Huyemore. Oh, it looks like your language vocabulary is very limited. Please be full South Africans. I've not even reached half of the 11 languages. Ladies and gentlemen, I want to start by thanking the presidency and the president himself for holding health in a very high regard in terms of priority. Since President Ramaphosa assumed office in February 2018, on various occasions, whether it be in the State of the Nation, but also on every occasion, he has made a very clear commitment to holding health as a very high priority. The first presidential summit, which was held here in this very same complex from the 19th to 20th October 2018, laid the foundation for the areas which the country needed to focus on, which Ms. Zondi just went quickly through. If we're to be able to get anywhere closer to our dream of providing good quality health services to our people, these are the key areas which we needed to focus on. Now, these 9 areas which she has just reflected on were subjects of discussion during that first summit in the groups, and as through reflected by Prof. Shisana and Ms. Zondi in the detailed report now, this also went on to constitute the pillars of the compact through which the various partners to that compact committed themselves. And I must emphasize that this was not just the commitment of government. As Prof. Shisana was indicating there, the number of partners and participants in the summit and also signatories to the compact, we must emphasize that the compact binds all of us, not only government. Of course, government as taking the most responsibility as the main institution to provide the services, but as already she emphasized the fact that we acknowledge that on our own as government, we cannot be able to achieve all those goals. So as a result of that, of course, today we're back here to come and review how far we have gone. These 9 focal points of the summit and the compact were not simply thumbsucked, but they were properly researched in terms of the value of those areas as the key performance areas which are critical if we are to be able to turn around our health system for the better. It is a well-documented fact that the evolution of the modern, or if you may call it, Western form of organized health services, because prior to the westernization of our health services, we did have indigenous health services. But if we look at the modern or the Western health services in our country, it has been bedeviled and has been intertwined with our historic political system. Prior to the dawn of democracy in 1994, the health system was organized along the lines of colonial and apartheid policy, with different facilities for white people, for Indian people, for colored people, and also for Africans. And of course, as in all other sectors of society, Africans were at the bottom end of the ladder in terms of those systems. I'm reminding us of this because I'm sure as we are 29 years of freedom and democracy and will be 30 years, many of us, memory fades and we forget where we come from. And I think in trying to design the way forward, as they say, it's always very useful sometimes to also know where you come from. By 1994, the private health sector was a very small, made out mainly of general practitioners, a small number of private specialists, and also other professionals such as dentists, physiotherapists, and a few laboratory services in the private sector, and indeed a much smaller sector in as far as the private hospitals were concerned by 1994. So we can say that the burgeoning of the private sector can correctly so be described as a democratic dividend. In business, we talk dividend. So we can say that private sector has actually, been rewarded with dividends as a result of the democracy. And that's where we are today. We can also, even when we look on the funding side, the growth of the medical scheme industry has also grown in leaps and bounds to the benefit of democracy. Over the last 29 years, I was just looking at the biggest medical scheme in the country currently, Discovery, that it was launched in 1992 as a small business, as a small insurance. And the medical aid industry also has benefited from democracy. Over the last 29 years, while the racial segregation which determined the quality of health services one could access during those days has been done away with, this has been replaced by differentiation by income, and therefore your class in society determines your access to particular services. It was therefore correct that the 2018 Presidential Health Summit did not only focus on improving the public health system, but also on how to close the gap between the two, the public and private, and an acknowledgement also that ultimately it is only the achievement and implementation of universal health coverage which can create a long-lasting equity in the access to health services. The public health system faces a number of challenges, key amongst which is the high burden of disease. Prof. Shizana has already tabled some of, from the communicable to non-communicable, which leads to a huge demand for service, while resources are continuously reducing as a result of poor economic performance, which is leading to declining revenue and allocation to the public health system. Undeniably, even with the limited resources, many of our public health facilities could perform better if it was not for inefficiencies, poor management, neglect of duty due to poor supervision. But also we must acknowledge that unfortunately also even outright corruption also does eat into the capacity of our public health system. Examples of that has been abound in the public. Despite these weaknesses, the public health system has proven to be resilient, even under the most testing pressure of the COVID-19 pandemic. While there were days, especially at the peak of the waves, care and ICU beds, and even commodities like oxygen, our system, as we did not see here in South Africa, the kind of scenes of what we saw in the media, in our televisions, of New York, the state of New York, where things were really, at some stage, reached collapse. Even in big countries like India, where the services were almost collapsed, even though we reached the ultimate, our systems were stretched to capacity, and there were days when we could not provide, but never reached really that kind of stage. In a number of hospitals, we had to lay out field hospitals, both in the public and the private, but we really never reached the stage where there was total collapse. And now that the COVID has now reduced quite drastically, we are now in a position to can start the real rebuilding and repositioning and rebuilding of our systems. Ordinarily, on any given day, millions of South Africans receive acceptable service at many public health facilities. And I use the word acceptable guardedly because of the fact that we acknowledge the fact that in many cases, with the pressures which I've mentioned, it might not be the best, but many lives are being saved on a daily basis in these public health facilities. There are even pockets of excellence at many of the public facilities, both at the primary level, at our primary clinics and health centers, but also at public specialized services. But we acknowledge the fact that these pockets of excellence, unfortunately, are drowned by the negative experiences which people have, and this is the stories which capture the limelight. Just to illustrate a small example of the differences in terms of pressure, the other day I was at Prince Mshini Hospital in Durban, and I was informed that at Prince Mshini they delivered between 900 and 1,000 babies a month. And just to give another indication of the pressure on the public health, here in Gauteng, MEC for Gauteng will attest to that. Chris Hani Baragwanath Hospital delivers between 1,500 and 1,800 babies a month. Now, happened to be in Durban, and I happened to bump against one of my old friends, colleagues, who's in the private health sector, who operates in some private hospital, and I was asking, how many deliveries do you do in your hospital? And he said to me, at the best, is between 60 and 80 deliveries a month. Now, across the road, you have a Prince Mshini Hospital, which delivers almost 30 to 40 babies a day. And across the road with the private hospital, they are lucky to have delivered 3 babies in a day. So when you look at the pressure, you can take this into many other services, and it tells you what do they call it? The cheese and chalk difference in terms of the amount of pressure which the public health sector faces on a daily basis. As is well documented, and Prof. Shisana also spoke to it, by the Council for Medical Schemes, the expenditure on private health, excluding out-of-pocket expenditure, is just a little bit higher than the total expenditure in the public health sector, just over 250 billion per annum, while only servicing 15% of the population. And as unemployment grows, more people are being pushed to depend exclusively on the public health system. Even those employed and on medical schemes are suffocating under the ever-increasing pressure of contributions, monthly contributions from their salaries, and are therefore continuously making demands on employers to increase the employer contribution to their medical cover and also from our side in the public sector. I'm sure I heard that the comrade president of COSATU is also here. I'm sure she can confirm that the public sector unions are also continuously making demands for the employer, the government, to increase its contribution because of the pressure of the cost of private health care. So anybody who denies the fact that the current path of our two-tier health system is not sustainable, I will regard such a person as a denialist of reality. Of course, for those who see health simply as another business opportunity, that would not be an issue, the fact that this system is unsustainable. The need for reform of the current trajectory, therefore, should not be a matter of debate, even where we may differ on the details of how that reform should take place. So we would disagree with those who argue very vigorously that what those of us who are leading in the health sector, we should simply concentrate on improving the public health rather than worrying anything about the reform of the entire system. We would say that, that's not the correct way to go. The COVID-19 pandemic, which broke out just 6 months after the signing of the compact, had the effect of derailing our focus on the systematic implementation of many of the pillars, with a lot of energies, both in the public and private sector, as we had to bring our resources together. Most of our focus and resources were turned into the mitigation of the impact of the COVID-19 pandemic. On the other hand, there were some lessons in terms of some of the implementation of the mitigations against COVID-19, complemented the pillars and accelerated some of the work in terms of, as we're intervening against the pandemic. In some areas, we're able to move closer between the private and the public sector. Mrs. Ondi has already done a good job in terms of just giving us a reminder of the areas of focus, but I'll just touch on some of those areas again. In the area of human resources on Pillar 1, let me at this stage take this opportunity again, as we talk about human resources for health, to express our gratitude on behalf of government and South Africans as a whole, to all our health workforce for having put their lives on the line in saving many, many lives in the fight against COVID-19. I think we should also take this opportunity to pay our respects to those who lost their lives in the line of duty, as we are all in this battle to save lives under the pandemic. May their souls rest in peace. The 2018 summit, correctly so, as has already been indicated, put a lot of, the reason why human resources for health was number one was not by mistake, because there was almost unanimity in agreeing that the human resources for health is at the center of any improvement in the quality of service. There has been some progress, thanks again to the presidency. Quite early, there was a presidential stimulus package, which was funds which were reallocated within the budget, and which made sure that we could employ more and more health workers across the system, both some at national, but largely many provinces benefited from that allocation of the stimulus package. But also, during the process of the high levels of COVID-19, we must remember also that the president instructed the Minister of Health to find funds during those difficult times, and 20 billion rand was reallocated to the health sector. And as a result of that, we're able to hire a lot more workforce across various categories of the health workforce. Unfortunately, as Prof. Chisana mentioned earlier on, because this was a particular allocation, it was not sustained. Some of those employments, many of those were on contract, they will be sustained for some time, but as the funds dried up, some of those posts have not been able to be retained. But I'm sure the breakaway group, which will be dealing with the human resources for health, will be able to look deeper into this. And I would urge them also to look at other difficult issues, which, of course, some of us must go to places like in the public service, the bargaining service, the public service bargaining chamber, issues like your occupation-specific dispensation, which is also putting a lot of pressure on the compensation budget within the public service, and also the remunerative work outside the public service, the RWAPs, which causes also a lot of problems in terms of the quality of service in many of our, especially not only service, but also teaching in many of our central hospitals. I'm sure that team will look at that. The area of access to essential medicines and other commodities, of course, in this area, we cannot forget the experience of COVID, where we struggled to access very essential vaccines as a result of the hoarding of the vaccines when they became available by the developed world. Finally, when they were covered, we were able to access those vaccines. But as a result of that, already by that time, the anti-vax movement was also building momentum. And as a result, by today, as we speak, we're sitting with over 25 million doses of the COVID-19 vaccines and with very little uptake. So we are struggling to see what we're going to do. There are still some few. So I just want to remind people that the COVID is not over. So those of you who have not yet had your boosters, please come forward. It's still available. We still have 25 million doses. So don't feel shy to come forward. The winter is coming, and especially those of us over 50 and over 60, let's please come forward to get our boosters. A lot of work also has happened in this area. Our CCMDD, chronic medication dispensation, which distributes medicines into various peripheries where people can pick up. I think Ms. Zondi reported a little bit on that. It's also gained a lot of momentum, but we just need to look at the funding for that program because it's reducing pressure on the health facilities. I must say that in this area also, I'm sure those who will be in this team will discuss it, but sitting where I am, I'm quite satisfied with the fact that over the last few years during COVID, of course, we struggled with the vaccines, but diagnostics sometimes, oxygen, but we're able to stabilize. But in terms of the general pharmaceutical commodities, over the last few years, we haven't really had major pressure of shortages. I'm sure if I'm wrong, colleagues who are in various sectors of health will tell us, but it does look like our stock visibility system is functioning. Whether we talk about antiretrovirals, whether we talk about other medication, chronic medication, we haven't had major pressure, except situations where provinces have not budgeted properly, have not managed their budgets. But in terms of availability, in terms of the stock availability, except where provinces have not budgeted properly, we have not had major problems in this area, but I'm sure there can be a lot of improvement. Infrastructure area, a lot still has to be done. The plans have been done, costed. We've been discussing with Treasury, including with the Minister of Finance. What we accept in this area is that the needs are huge. The study which was done in terms of this, the infrastructure needs in the public sector in 2019 showed that the gap of funding which was required just for hospitals was about 70 billion rand. If we are to be able to address all our shortcomings in terms of the capital works in the infrastructure area, just for hospitals, and just over 12 billion required for primary health area. So what we are key to this, what we are looking at is the alternative methods of funding, because we have accepted the fact that on an annual basis from conditional grant on infrastructure, we provide just about 9 billion rand in terms of allocation conditional grant, over and above the equitable share from which provinces can also use for upgrading infrastructure and maintenance. But we accept the fact that if we're going to depend on this we're never going to catch up. So we're working with Treasury on alternative funding methods, what they call blended finance, PPP, and other ways through which we can be able to address the infrastructure area. I think a lot has already been said about engagement with private sector. I think a lot more, I hope that during the course of this summit, there will be a lot more concrete proposals on how we can improve the collaboration between the public and private sector. Some work has been done during the COVID, but just looking at in terms of the access to beds, ordinary beds, and also high care ICU beds, there was some work which was done at the height of COVID, but in terms of being able to make a significant way forward, the impediment there has been the issue of costs, because private hospital beds, especially when you start talking about ICU, are very costly. So those are the things which we need to look at, how we can bring the cost down. Of course, information systems, the EVDS, where we all used one system in terms of the vaccination data system, whether public or private, is a good start, but we need to get more. We need to move more further into the broader health information system so that we can be able to have the same platform, whether you are in the public or private sector. What we hope going forward is a situation where as patients move within the public sector, between provinces or different levels, we can have one identification and can be able to track the movement of people, but also, hopefully, also into the private sector as well. The improvement of quality, I think we've already said a lot about that. Some progress has been made, both at the primary level, but also at the hospital level, and including at the specialist services level. But again, a lot still need to be done to make sure that we can improve the quality, but we're quite satisfied that with the relaxation of the pressure by the COVID pandemic, we will be able to do a lot more. The financial area also, we do have challenges in the sense that, as I've already mentioned, with the reduction in revenue collection by the revenue services, and therefore the funds available for Minister of Finance, it hits us quite hard. Even in the current financial year, our budget, even before you consider inflation, our budget allocation is just not enough to address some of the challenges which we still have to deal with. Of course, again, the area of governance, the issues dealing with corruption, the SIU has done quite a good job. There are a number of cases which are still being followed. Others have already been dealt with. And I'm sure we'll do more work under the Anti-Corruption Forum to make sure that our governance systems also improves. But I must also say that appealing to also our political leadership, that leadership and management stability has proven to be very key in terms of the performance of our health systems. In provinces and institutions where there's been stability of management and leadership, you see the difference over time. And I can also just mention that even recently, just over a month ago when we had the public service strike, there was a lot of difference in terms of how various provinces were able to manage the disruption of the strike, and that also reflected on the stability of management and leadership. So if we can have, I know that especially at the political level, it's a difficult area to can expect always stable leadership, but it helps if there is stability both at leadership and management. Information systems, I think we've already said a bit about that. On this part, the only thing which I want to say is that we really would want to see a lot more improvement in terms of access of information, especially in the private sector. It is quite unacceptable where we are, that we hardly have any clinical data from the private. I mean, the private sector is quite big, especially the hospital sector. But whenever you will hear reports on whether it's the district health information system or any other public health information which we publish, you must always take into consideration that exclude information from the private health sector. So that's an area, a gray area, which we need to address. And we are going to be also in line with the report of the Health Market Inquiry. We are going to be a little bit more stronger in that area. So I'm just giving a warning to our colleagues in the private health sector that we will be talking to you to try and nudge you into a much more cooperation in as far as, because that data, the people who use your services, whose clinical, not individual clinical information, but just the data in terms of, whether, just for instance, talking about deliveries. I gave you an example of the gap in terms of the services demand in the public sector and private sector. And one of the key issues, which even this colleague of mine who was telling me about the deliveries, and I've also heard from other sources, I think we do have the information also, I'm sure, from CMS, from the limited numbers of deliveries, even in this particular hospital where I was getting the information, 70% are cesarean section, 70%. And I was informed by the other day when I addressed the pediatricians, and they were very unhappy. They were actually saying that in some private hospitals, 90% cesarean sections. So you can see that there's something wrong there. So we want that information. We don't want to get it anecdotally or indirectly from CMS. We want that information directly. So ladies and gentlemen, we're really looking forward to your robust contribution as we break into groups during this summit. The President will join us briefly tomorrow, and I'm sure he's looking forward to a report which will indicate that this was time well used. I want you to disprove the doubting Thomases. I won't mention who they are, who have been writing in some places that this is just going to be a talk shop. I'm sure you're going to prove them wrong, that this is not going to be a talk shop. It's going to be a very productive summit, which is going to review where we are, look at what we have, the momentum we lost a bit as a result of the pandemic, where are the areas where we need to pick up, and how do we actually move speedily, as already indicated, as to the aims and objectives, so that we don't wait. Our colleagues and comrades in Parliament are doing their best in making sure that we can have the legal framework, but we can't be given that as an excuse in terms of improving the services. We must do our best. They will do their part in terms of passing the legislations, but we must do our best in terms of improving quality, and also maybe making sure that the gap between those who have income and those who depend completely on the public service, the quality of service can be the gap can be narrowed, and everybody can move closer to experiencing equity in the access to our health services. Thank you very much.
Thank you very much.